Thank you, Bonnie. Well, you know, Bonnie, you're right. Minnesota leads in so many ways, and certainly, and I'm in the seat of actually, Franni and I are in the seat of a couple, Paul and Sheila, who live away on domestic violence and also on healthcare parity, which are both very important to both of us. When we decided that we were going to run, I told our friends, I said, Franni and I are running for the Senate, and if we win, I get to be the senator. And we won.
Turned out to be
true.
Here he is.
Yeah, and you know how close this race was, and you know that Franni, not only would I've lost him, I actually kind of lost my, probably quite a lot. As I was saying, it's great to be a senator from Minnesota when you're doing healthcare, because we do better than the rest of the country. Now that's on a curve. It's on a curve. Probably the most influential piece of writing, I think, in this healthcare debate among people who are serious is the Atul Gawande piece in the New Yorker on the differences between McAllen, Texas, and Rochester and Mayo, and McAllen being the most expensive healthcare market in the country, and spending 3 times as much per Medicare patient as Rochester, and about twice as much as El Paso, which has the exact same demographic as McAllen. And the second day I was at the Senate, I was on the subway with John Cornyn, senator from Texas, Republican, and we started talking and got on to healthcare, and he, was shaking his head about McAllen and about how well we do things up here in Mayo. And I felt like the parent who, his kid got an A, and he was the parent whose kid got an F. And it was a good feeling. And but we did, as I've done a lot of healthcare forums, and I had on one there was a healthcare economist who said, well, we get an A here, but it's only because we grade on a curve, and we can do a lot better, and we can certainly do a lot better in terms of the healthcare disparities. And healthcare disparities especially by socioeconomic factors, and talking about certainly our native population is the Indian Health Services is not doing its job, but I'm talking about just so much of your health care has to do with where you live. It doesn't have to do with your doctor. It doesn't have to do with your insurance company. It has to do with, do you have clean air? Do you have clean water? Do you have fresh vegetables and fruits? And are they not only available, but inexpensive enough to actually eat? Are they part of your diet? Is the school safe? Is there violence in your neighborhood? Is there addiction? Are there places to exercise? Are there places to socialize? And these have so much to do. The healthcare disparities in this state are as large as they are in any other state. And that's partly because we do so well at the top, but we don't do so well, obviously, at the bottom. And the same is true in terms of women of color and women who live in poverty. And so that's something I want us to be talking about today. Let me introduce Lauren for those of you who don't know Lauren. First met Lauren on the phone. My prospective chief of staff, I started staffing up. Many of you may know there was some time between the election.
Couple days.
It seemed like only a couple days, it just flew past, didn't it? But it was actually 8 months. And and at a certain point it appeared that we would likely win. And so I started putting a team together, and my prospective chief of staff, I said, well, I knew that if I was seated, I'd be on the Health, Education, Labor, and Pension Committee, and I wanted an update on what was going on there on healthcare. And he put me in touch with Lauren on the phone, and we hit it off right away, I'd say, for a whole bunch of reasons. Lauren is quite brilliant and knowledgeable, and this is her life and her career. She's from, she's not from Mayo, she's from, she was incubated. Well, it's an experiment. No, her father was head of pediatrics at Mayo, so she's from Rochester, that's what I was going to say. And educated at the U, master's in public health from the U. And she has really walked the walk on health disparities and trying to get health care to communities that are underserved and at risk. And very early on in our conversation, I started talking about healthcare disparities, and I heard her, because she was telling me what was going on in the committee, and I sensed you excited that I was actually talking about that. And we talked about some of the stuff that's happening on the bill in the health committee, and that Senator Harkin was head of the prevention title, and that there is a focus on, real focus on prevention. You know that all preventive health care will be paid for in this, and that we're going to get rid of pre-existing conditions. This is not so much prevention, but pre-existing conditions, including the pre-existing condition of having had a C-section, which is evidently a pre-existing condition for some reason, and according to some health insurers. And and not denying people based on on their health history, and not penalizing them in their insurance, and making sure that family planning funding is done fully, and that we do the kind of preventive care that will ultimately just pay huge dividends in terms of cost, and that we're also going to focus on bending that cost curve. That's a cliche, but that's what we need to do in changing the way we deliver care. But actually, I think I'm going to stop talking now and open this up, because I want to hear from you. I want to listen today and answer any questions.